Welcome to the Deep Dive. Today, we're going to be diving into the world of uveitis treatment. Specifically, we're going to be looking at non-biologic immunomodulatory agents.
Okay.
You sent us a selection of research excerpts on this topic, and it seems like you're really interested in going beyond the typical corticosteroids to understand like all the different options for managing uveitis.
Right.
So our goal today is to kind of sift through all these, dense medical texts and try to, extract the key takeaways and explain what it all means in a way that's both informative but also hopefully engaging.
Sounds good.
So I have to admit, even I, feel a little intimidated by the sheer variety of these immunomodulatory medications.
Right.
Anti-metabolites, T-cell inhibitors,
Right.
alkylating agents. It's a lot to wrap your head around. But I'm hoping that we can uncover some patterns and really interesting details sort of hiding within these excerpts.
Yeah, you're absolutely right. The names can be a little daunting. But when we break them down into those three categories that you mentioned, anti-metabolites, T-cell inhibitors, and alkylating agents, we start to see how each one tackles the immune response in a different way. And so each has its own set of advantages and potential downsides.
Okay, let's unpack this a little bit. When we talk about potential downsides, I immediately think about side effects.
Right.
So what should we know about the safety profiles of these different categories of medications?
Yeah, that's a crucial question. We need to remember that we're essentially trying to fine-tune the immune system.
Yeah.
And that can sometimes lead to some unwanted effects. So let's start with the anti-metabolites medications like azathioprine, methotrexate, and mycophenolate mofetil. They're generally considered the first line of defense when moving beyond corticosteroids because they tend to be well tolerated.
Okay, so when might a doctor choose one anti-metabolite over another?
Yeah, so that's where the nuances come in. For example, azathioprine. It's a very effective drug, but it can be a bit tricky because people metabolize it differently due to genetic variations. So some people might need very careful dose adjustments to avoid side effects.
I see.
Then there's methotrexate, and methotrexate is often the go-to choice for children with uveitis associated with juvenile idiopathic arthritis, or JIA.
Okay, so why is methotrexate particularly well-suited for children with JIA-associated uveitis? Is it something about, how it works on a molecular level, or is it more about the, the long-term safety profile in younger patients?
Yeah, it's likely a combination of factors. Methotrexate is particularly good at controlling inflammation in the joints,
Okay.
which is a key feature of JIA.
Right.
Plus, it's been used for many years in children with JIA. So we have a really good understanding of its long-term safety profile in this population.
Got it.
Of course, it's not without its downsides. Methotrexate requires folic acid supplements to mitigate side effects like mouth sores and fatigue.
Right.
And then we have mycophenolate mofetil. And mycophenolate mofetil has a shorter time to efficacy, meaning it starts working faster.
Oh, that's good.
But it can't be used during pregnancy.
Oh, I see. Okay, so each of these antimetabolites has its own personality, so to speak.
Yeah.
So what about T-cell inhibitors? Where do they fit into the picture?
So T-cell inhibitors like cyclosporine and tacrolimus are really effective.
Okay.
But they can pack a bit more of a punch when it comes to side effects.
Like what?
Oh, we're talking about things like high blood pressure and kidney problems. Tacrolimus seems to have a slightly better safety track record compared to cyclosporine, though.
Oh, okay. So I imagine that makes choosing between them, a bit of a tightrope walk.
Right.
Efficacy versus side effects. It must be a tough decision for both the doctors and the patients.
Absolutely. It's about finding that sweet spot, weighing the potential benefits against the risks.
Right.
And that's why that close collaboration with your doctor is so crucial.
Yeah, that makes sense. So if these T-cell inhibitors are sort of the middle ground, where do alkylating agents fit in?
So alkylating agents like cyclophosphamide and chlorambucil are like the heavy artillery.
Right.
We reserve them for the most severe, stubborn cases of uveitis.
Wow.
They work by suppressing the immune system more broadly, which can be very effective, but it also comes with a higher risk of serious side effects, including a potential for malignancy.
Oh, wow. Okay, so that sounds intense. I can see why these would only be used in very specific situations.
Exactly. It's a careful risk-benefit analysis.
Right.
And close monitoring is absolutely essential if these medications are used.
So we've got this spectrum of medications, each with its own strengths and weaknesses. It seems like choosing the right medication would depend on a lot of individual factors. The type of uveitis, its severity, the patient's overall health, and of course their comfort level with potential side effects.
You've hit the nail on the head. It's about personalized medicine, finding the best fit for each individual patient. It's not one size fits all.
As I was reading through the research, I was really struck by how these medications are used for such a wide array of uveitis conditions.
Yeah.
We see them mentioned for everything from Behçet disease to JIA-associated uveitis to sympathetic ophthalmia. Is there a reason why certain drugs might be preferred for certain conditions?
That's where it gets really fascinating. The choice of medication often depends on the specific type of uveitis we're dealing with. It's like matching the right tool to the job.
Right.
For instance, azathioprine has a really good track record with Behçet disease,
Okay.
where it helps control inflammation in the blood vessels. It's also shown promise in managing other conditions like intermediate uveitis, Vogt-Koyanagi-Hirata syndrome, sympathetic ophthalmia, and even necrotizing scleritis.
Wow, that's quite a list.
Yeah.
What about methotrexate? We already talked about it in the context of JIA-associated uveitis, but does it have other applications as well?
Yeah, methotrexate is incredibly versatile.
Mm.
It's also effective for sarcoidosis, which is a condition where inflammatory cells kind of clump together in various organs, including the eye.
Oh, wow.
And it's often used for panuveitis, which affects all layers of the eye, and scleritis, inflammation of the white part of the eye.
It's like a Swiss Army knife of uveitis medications.
It is.
Speaking of methotrexate, I came across something particularly interesting in the research.
Okay.
It mentioned using methotrexate directly in the eye.
You're talking about intravitreal injections of methotrexate.
Yeah.
Yeah, it's a relatively new approach where we bypass the bloodstream and deliver the medication directly to the affected area.
Wow.
This could be a game changer for certain patients,
Yeah.
especially those with uveitic macular edema, which is swelling in the central part of the retina that can lead to vision loss.
Right.
By delivering the medication directly to the eye, we can potentially achieve better results with lower doses and fewer systemic side effects.
That is fascinating. So to sum up, when choosing a non-biologic immunomodulatory agent, we're looking at a complex interplay of factors. The type of uveitis, its severity, the patient's overall health, potential side effects, and of course, close monitoring by their healthcare provider. Did I miss anything?
Nope, you captured it perfectly. It's a complex dance between all those factors you mentioned, and that's precisely why that close collaboration with your healthcare provider is so vital in managing uveitis. It's not a DIY project.
Yeah, it really highlights the specialized knowledge that goes into treating uveitis, doesn't it?
It does.
It's not just about, picking a medication off a shelf.
Right.
It's about understanding all those nuances of each one and tailoring the approach to the individual patient.
Absolutely. And it's a constantly evolving field. As we learn more about the immune system and the specific drivers of inflammation in different types of uveitis, our treatment strategies become even more refined.
Speaking of evolving treatments, I noticed in the research that alkylating agents seem to be used less frequently these days. While biologic therapies are getting a lot more attention, is this a trend we're seeing across the board in uveitis treatment?
Yeah, you've picked up on a very important shift.
Okay.
The landscape of uveitis treatment is rapidly changing, and biologics are definitely making a big splash.
Yeah.
They offer a more targeted approach to immune modulation, which often translates into a better safety profile compared to some of the older, less specific medications, particularly those alkylating agents we discussed.
So does that mean that non-biologic agents are on their way out? Are they becoming obsolete in the face of these newer biologics?
That's a question that many researchers and clinicians are grappling with right now.
Yeah.
It's fascinating to see how this field is evolving. While biologics have shown incredible promise for many patients,
Right.
they're not a universal solution. For one thing, they can be quite expensive,
Oh, yeah.
which can be a major obstacle for some people,
Yeah.
especially those without comprehensive insurance coverage.
That makes sense. Accessibility and affordability are definitely crucial factors, especially when we're talking about a condition like uveitis that often requires long-term management.
Absolutely.
So where do non-biologics fit in? Do they still have a role to play?
Absolutely. Non-biologics remain incredibly valuable tools in our toolbox.
Okay.
They have a longer track record than biologics, meaning we have decades of data on their safety and efficacy.
Right.
This is particularly important when considering potential long-term effects. We're still gathering that kind of data for biologics.
That's a really important point. It's almost like comparing a well-worn map to a brand new GPS system.
Right.
Both can get you to your destination.
Yeah.
But the map has the benefit of being tried and tested.
Exactly.
So it's not an either-or situation.
Exactly. It's about having a range of options
Right.
and choosing the best fit for each individual patient. In some cases, non-biologics might be the preferred first-line therapy, especially for certain types of uveitis or for people who can't tolerate or afford biologics.
I'm starting to get a sense of just how complex these decisions really are.
Yeah.
Given everything we've discussed, how do doctors determine the best course of treatment for a patient with uveitis?
Well, it's a multifaceted decision-making process.
Okay.
It starts with a thorough evaluation, understanding the specific type of uveitis, its severity, the patient's overall health, their lifestyle, and their preferences.
Okay.
Then we consider the potential benefits and risks of each medication class and individual drug, factoring in things like cost, potential side effects, and the patient's comfort level with different monitoring requirements.
It's really about weaving together a tapestry of information, isn't it?
You've put it beautifully.
It is. The patient's story, the doctor's expertise, and the ever-evolving landscape of treatment options.
Yeah, it's a collaborative journey between the doctor and patient working together to find the best path forward.
Okay, we've covered a lot of ground here.
We have.
We've talked about the different classes of non-biologic immunomodulatory agents, their mechanisms of action, their benefits and risks, and even how the treatment landscape is changing with the advent of biologics.
We have. It's been a great exploration.
Yeah.
We've delved into the complexities of managing uveitis and how these different medications can be used to help patients regain control of their eye health.
Yeah, this has been incredibly insightful, but it's important to remember that what we've discussed today should not be taken as medical advice.
Absolutely. This is a complex topic,
Yeah.
and each individual situation is unique.
So, as always, we encourage our listener to consult with their healthcare provider for personalized guidance and treatment recommendations. Before we wrap up this deep dive, I want to leave you with one final thought to ponder.
I love a good thought-provoking question.
Okay, what do you got for us?
What have you got for us?
Given the exciting advancements we're seeing in biologic therapies, what does the future hold for non-biologic immunomodulatory agents? Will they eventually fade into the background, or will they continue to play a significant role in the management of uveitis? That's the million-dollar question, isn't it? It's like we're trying to predict the ending of a movie that's still being filmed.
It really is. But I think it's safe to say that non-biologic immunomodulatory agents will likely continue to be important players in the uveitis treatment landscape, for the foreseeable future.
Okay.
And there are a few reasons for this.
Okay, I'm all ears. What makes you think they won't be, completely replaced by biologics? I mean, biologics seem to be all the rage these days.
Well, for starters, non-biologic agents have that long track record we were talking about.
Right.
We have decades of experience with these medications, which gives us a really solid understanding of their long-term safety profiles and how they work in different patient populations. It's like that familiar recipe you've been using for years.
Right.
You know it works and you know what to expect.
Yeah, that's a good point. Familiarity and predictability are definitely reassuring, especially when it comes to something as delicate as the immune system.
Right.
But what about efficacy? Aren't biologics more effective because they're so targeted?
Well, while biologics are very effective for many patients, it's not always a clear-cut case of newer is better. Some people don't respond to biologics, or they may experience side effects that make them unsuitable for long-term use.
Right.
And let's not forget the cost factor.
Yeah.
Biologics can be prohibitively expensive for some people,
Right.
which limits access for those who might benefit from them.
So it's about finding the right balance. Right?
Exactly.
Weighing efficacy, safety, accessibility, and affordability.
Uh-huh.
It sounds like non-biologic agents still have a lot to offer, even in this age of, cutting-edge biologics.
Exactly. And as we gather more data on biologics, we'll gain a clearer understanding of their long-term effects and how they compare to non-biologic agents in terms of overall effectiveness and safety.
Yeah, it's a fascinating time to be following this field. So much innovation and ongoing research.
Yeah.
I have a feeling we'll be revisiting this topic again in the future as new discoveries emerge.
I agree. The future of uveitis treatment is full of possibilities, and it's exciting to think about the potential for even more personalized and effective approaches.
Well, I think we've successfully navigated the complex world of non-biologic immunomodulatory agents for uveitis treatment.
I think so.
We've covered the different medication classes, their mechanisms of action, their benefits and risks, and how they fit into the ever-evolving landscape of treatment options.
We've certainly covered a lot of ground. Hopefully our listener feels more informed about this crucial aspect of managing uveitis.
As always, we want to remind our listener that the information we've discussed today is for educational purposes only and should not be taken as medical advice.
It's always best to consult with your healthcare provider to discuss your specific situation and determine the most appropriate treatment plan for you.
And on that note, we'll wrap up this deep dive into uveitis treatment. Until next time, keep exploring, keep learning, and keep those questions coming.